pharmacist by choice, very small fraction would probably take it by choice. Still people want to do jobs in manufacturing or R&D in the pharma companies. So that's a big factor which we have to solve, which ultimately falls into the remunerations which people get, the future potential of your profession and all that. The community pharmacy in reality has not picked up in this country because of the social structure which we have. Otherwise, the capacity building for anything to do with healthcare, these pharmacists, community pharmacists have to play a very strong role. With all, I mean, if you see doctors, nurses, other health technicians, you will find them concentrated in hospitals. But in the society, if you see the spread, the most basically the biggest possibility is for any profession in healthcare, it is for pharmacists through the whole retail chain distribution, supply chain management. And they are the people who can actually contribute up to the last mile of the value chain. So this this needs a strong change management. The change is happening, but I think it would take some more time because it's a professional and mindset change and thinking change for pharmacists.
Thank you so much. I think very important point that it's more about mindset change than just technology. Uh, Dr. Sarvajit Kaur, we are very fortunate to have you with us as the Secretary of the Indian Nursing Council. You represent 2.2 million nurses and more probably. If we account for every registration is 3 million, so which is like 10% of the world's nurses. How are nurses coping up with the changes in technology with regards to healthcare? And what are you doing at INC?
Thank you, Dr. Gupta, for this question and for this opportunity to be here in this esteemed panel. To answer your question from the regulatory point of view, we have tried to integrate the AI and the digital health into the basic nursing curriculum. We had a change of the BSc nursing curriculum in 2021, and we have started by putting the emphasis on building competencies through the digital health and AI. So 5 simulation labs have now become mandatory. We have given lab equipments, the list of mannequins, VR, etc., that can be used to build up competencies, because we are also seeing that the clinical facilities that are out there for the nursing students to build up those competencies is becoming limited. We are having almost 2.5 lakh nursing students getting passed out for GNM and BSc, like both getting registered as registered nurses, registered midwife. So we have started from scratch, if I can say so. We have started with computer education. We have made given guidelines like for every 5 students, there should be 1 computer. We have given computer labs right out there. And we have also worked towards faculty preparedness. So there is, complete adoption, like the panelists brought out, this has to be a change of mindset. So even if you have these expensive equipments out there, how do you use them and not just keep them in the cupboards, safe as an inventory articles? So we have started with 2 national reference simulation centers, one in Gurgaon and the other one just recently opened last 2 months back in the south, Bagalkot. And we've started with faculty preparedness. For the Gurgaon NRSC, we have trained around 2,000 faculty on how to use these, simulators for each and every nursing student. So what, as a regulatory body, we are looking is for each and every nursing student to embrace the digital technology as she is working to be a nurse, to build up her competencies. And even for in service, we are linking it up. As you're aware, with a lot of push from your side, we've had this professional digital nursing course of 6 months, which a lot of takers are there in nursing who are wanting to do this, but I think we need much more courses like that. We are linking it to CNE hours. We have also brought out our online registration system for the nurses, which again, we are trying to link it with all these kinds of opportunities for them, so more nurses benefit out of it. And in the abroad, if you see, we are having these chief technical nurses also now were trying to resolve issues like staffing, prevention falls, policies to improve nursing. So I think we here also in India need to do a lot in terms of policies to empower every ANM who is working in the rural, or every community health officer who's working in the Arogya Mandirs, or every nurse who is wanting to do better for her patients in the super specialized hospitals. There's a lot more to be done. Thank you.
Thank you so much. It's very exciting to see how you have moved to bring digital courses to nurses and the offtake for that. And I also keep hearing very positive feedback on this opportunity for nurses. Thank you so much. Now I move to Dr. Suresh Yadav, who I've known as someone who not just ideates the future but creates the future. So working with the President of India, whether he went to World Bank, whether he's in Commonwealth, even in Commonwealth, few years back, you put the agenda of AI as a high priority. What is your work and role today at Commonwealth's vision for the 56 member nations and more so for the small island states?
Thank you. Thank you, Professor Gupta, and thank you for your leadership in this very important stage. He has been working in this digital health parliament and global leadership when the world was not thinking. So it's a great contribution by you to the system, because digital has taken a front seat only during the COVID and the post-COVID. Before that, it was just like a digital e-governance systems around the world. Now, before I say anything, I'll be very general in comment on the global level and then touching a little bit on the ground level. What it cost the global ecosystem? Anish described when there was a financial crisis, what Global South that point of time called a crisis triggered by the Global North, naming that particular country. So and he described how beautifully President Obama steered the United States out of that very complicated and complex situation. Now, if you look at the shortages of the healthcare professionals to the global economy, what it costs, shortage is one part, it's number. Maybe somewhere 100,000 people short, somewhere more number. What are the global implications? So the economic cost of this shortages of the healthcare workers, which is around, in all the categories, around 10 to 12 million, almost cost 15% of the global GDP. And you can imagine that 15% of the global GDP of $120 trillion economy. So it's a huge cost. Just because we don't have people, it has a multiplier effect, and it's leading to the cascading effect on the various other segments of the society. The other thing which is happening is that the global temperature rise. If you look at the climate and health, there is a latest Lancet report which brings very beautifully how the climate is driving health and leading to a different kind of a challenging situation. But also on this other side, I wanted to say that how health system is also contributing to the climate, because one of the largest emitter on the planet. Now, given this situation, we know that so much is the shortages of the healthcare professionals, and the nurses shortage is so much that Anish, you will know better than I know that US has a special visa for the nurses. You may have a computer science degree but may not get a visa. But if you have a nurse experience certificate, you get a visa. So that is the level of, the challenges which the world is facing. Now we know that this is a challenge. What do we do? How do we do? How do we move forward? The other, before I go to that, the other challenge is the aging population. If you look at the Japan, if you look at the Nordic countries, the aging population number is rising. There are not many people to take care of that. Even if I have to get a healthcare worker in my village in eastern Uttar Pradesh, it's so difficult. Even if you want to pay the money, there are no people to serve you. So what do you do? One is, of course, the obvious solution that you train more number of people, because there are a lot of people who are looking for the job. It's not that people are not there. So how do you ramp up that capacity? I know in India, for creating a nursing school, you need to have an hospitals, and there are so many challenges in spite of setting up a lot of hospitals in the country. So one low-hanging fruit is the digital solutions. And on the top of that digital solution now is AI solution. Can I make one doctor serve 10 people? Can I make one healthcare serve more than 5 times, 10 times more using the technologies management of the system, using the health ERP like multinational enterprises are doing. The whole system is fragmented in the healthcare system. It should be entire ecosystem. The one good thing about the US is that the doctor, the pharmacy, everybody is connected. So that at least fragmentation is not there in the US system, but that fragmentation is still exists in the UK system. But in India, that silo is very much there. So even if using this health ERP on the lines of corporate ERP, if we are able to fix it, I think that will be an entire transformative approach of creating a very ecosystem approach where the health workers, the doctors, the nurses, those who wants to volunteer and contribute, they will be all connected. So that is one quick fix solution I see. The other I see that in the global market, and this was my pet project that, and particularly came out from the post-COVID, that there are doctors and who wants to do more, but they have a challenges. So how do you connect a global, or doctors without borders? How can an Indian doctor serve a patient in Kenya rather than Kenyan or Tanzanian patient traveling to India? Or if they have to travel, they should travel only small portion rather than a big time of 2 months, 3 months. So these technologies offers you that you can have your scans remotely, you can upload, send to the doctor, have all the diagnostic except the procedure which you are required to be there. So it's not only a country health ecosystem, but also a global health ecosystem which can be made available using the technologies. And I see that using that approach, any best hospital or doctor in the United States can be accessible to a patient in India or vice versa, because a lot of Indian wants to consult a doctor in India. My wife, who is in the US for 10 years, still believes in the Indian doctor and wants to have a medicine from India and this one. So 2 million, 20 million persons of Indian origin around the world. So India can connect 1.5 billion people within the country and 20 million people who still believe that I should have the Indian medicine, I should have the Indian doctor. So this is a huge opportunities for India to take the leadership, because you have the manpower, you have a lot of young people enter the job market looking for the job, and you have the digital technology power. The only question is to putting these two together and make the nursing institutes, the hospital administration, the startups be all the part of the thriving ecosystem. I think if we can do it, we will really rather recreating or reimagining a healthcare system, not only for India, but for the entire world. And this 15% GDP, this global temperature rise, the climate health nexus, which I can talk about, digital will be a great enabler, Professor Gupta, in solving those challenges. And I'm a very, very optimistic and futuristic person. And I'm sure that if not in next 10 years, by 2050, we will have a system where there will be universal health access cutting across the boundaries. Not that within your boundaries, but you can have access to rest of the world, of the medicine, of the supplies, of the doctors, of the procedures. So I'll stop here on this positive note and over to you.
Thank you, Suresh. This is very interesting. And I always like optimism over technology. Even if you're not optimism, technology will move fast. Coming to you, Zolikant, you are an entrepreneur in technology. While Dr. Rajiv approved DTX, you make DTX. You have made amazing AI-driven technologies. What's your take on capacity building? Do we have enough capacity to have more entrepreneurs like you? We will have ideators like you, but not entrepreneurs because we don't have executors. How do you define this?
Thank you, Rajenji. While, of course, I will be speaking on that part of technology as well, how we can create entrepreneurs. But I think more to the point that my fellow panelists talked about, I think technology, when it comes to capacity building, technology companies have a significant role because they influence how the current workforce is practicing, and also they influence how the next generation of a workforce will get trained. So that way we have a dual responsibility. And in that sense, I think there's a design principle that every technology company should keep in mind, or any budding entrepreneur should keep in mind. And that is that the way they design their AI or tech solutions, it should be in a manner that is scalable, not in terms of volume, but scalable in terms of complexity. Because if you're building something and if you're providing the healthcare industry with something, then you have to, particularly in a country like India, where you have a diverse spectrum of digital maturity across various institutes. Some hospitals might be digital native, some of them might be completely analog. So, in that sense, you have to have a product that handholds the healthcare workers through the digital transformation journey. So, the product is able to scale in complexity as the institutes scale in readiness. That's how we have been building products. As an example, our EISU solution, its functionality ranges from basic remote vital monitoring to more complex smart alerts and advanced clinical decision support systems based on the readiness of the clinicians. And that's something that every techpreneur should keep in mind. We shouldn't impose AI or technology. Rather, the technology should adapt to the capacity, or rather, it should be able to handhold the capacity and pull it up. One more point that I wanted to add was that just like technologists have been creating or co-creating the next generation of workforce when it comes to programmers and innovators, similarly, I feel health tech companies have a responsibility in co-creating the next generation of healthcare workers. So, with the academies like Academy of Digital Health Sciences, I think technology companies or specifically health tech companies should come forward and co-design some hands-on courses as well, like the one ma'am mentioned, the professional nurses course. So that we're able to expose the students early on to these developments and the flux that's going on. Otherwise, if we're training them in analog systems and they graduate into a technology first world, then there's going to be a structural mismatch always between what they have been trained for and the reality that they're facing.
So I'll have two questions to the experts before we move to audience questions. This is to first, Dr. Sarvajit, to you, because you're a regulator. You made an important point that you want to change. I mean, you have already done that by incorporating digital health as a part of the education. When I was writing the education policy, my biggest worry was technology moves with a pace that you can't change your curriculum every now and then, because by the time you go to the academic council, governing board, new technology has come. So is there a way you're looking at to make, I think you talked about CME, but is that the way we should looking at training all professions, adding CMEs rather than changing curriculum every now and then, because that's going to be really tough.
Curriculum changes normally occurs say once in a decade, and that also is a long process. When we brought out the BSc nursing change, we took almost 3 years to bring about a change with all the there's a whole process to it, including the public comments and bringing about changes. So yes, at that point of time, whatever is the best for the nursing students, we have tried to do that. But at the same time, we also need to understand that there is this like 40 lakhs, 4 million nurses already out there in the country in different states whose competencies also need to be built, because they are the ones who are working, be it in the rural or be it in the specialized hospitals. And for this, as a regulator, we push upon having simulation centers. That's what we are saying. One should be in every district, so that there are some states who have already started taking this, like we had Niramaya in Uttar Pradesh and we had Union in Bihar, where they are building up these competency centers, integrating the digital technology with it, certifying it, so that, and linking it to the CNEs. So the nurse carries it forward with her. There are incentives there for the nurses to come up for these programs and to better integrate this into the health systems. a lot needs to be done in this. And as you're also aware, with the Digital Health Academy, we are now working towards having a 1 year or maybe a 2 year program. We are still working that out. So when this also comes as a specialization, more takers will be there. I think it will again disseminate down. It's a mammoth task, no doubt.
Dr. Rajiv, I wanted to ask you on that point only, that you have drug inspectors across the country who were in the conventional, world. What are you doing for them to understand, and of course for pharmacists too? I want your point.
So, so before moving to that, I just had one comment on this one, the curriculum change, right? So this actually point comes again and again in pharma education also. And colleges and teachers say that we are not allowed to change. It is governed by PCI. But always I say one point. See, PCI or any body which actually sets the courses, they give you the minimum which should happen. They don't say that don't go beyond this. So you have all open at the top. Whatever you want to do, you keep this minimum, plus you go on adding if you want to. So if pharma is not having a course on innovation or management or any modern technology, computer programming, PCI doesn't say that you can't do it. PCI says that you keep pharma papers. Over and above this, if I want to keep innovation paper, I'm free to do that.
Rajiv,
So
I'm
that
sure this
actually-
message will go viral, but the problem is how many people read it in that manner. When we started courses, we put a line. The contents of this course will change based on the developments in the field. And we had really tough time telling that it can be in the prospectus. I said, we have to do that. The field is changing. And that brings me to Anish, because always the problem comes, what do you do to governments? When you're talking of technology, we can have regulators change it. We can have, councils change it. How do politicians get changed? Do we have a crash course for them?
Well, so here is the spicy question, but let me handle it. Well, this is in the U.S. It was funny when you saw the senators asking Mark Zuckerberg questions that were not very smart. So there was obviously a push to get education about what the technology means. But let me shift that question in a different way. A lot of this assumes that the job to be done is the same, but you've introduced new tools so that you train people on how to do the same job, but with the new tools. The politician or the policymaker is often focused on the outcome or the objective, the problem to be solved. And it may be that we've spent 10 years doing it this way, and we've funded it, organized it, and you should be educated on how technology will influence it. But at some point, there'll be a flip. Hey, I've got an entirely new way of solving that outcome. And why don't we reorganize this whole thing that takes advantage of new capacity that wasn't possible but for the technology? Earlier in this conference, we heard from Sunil Wadhwani from the Wadhwani Foundation. He talked about tuberculosis deaths, 500,000 deaths. And he said a portion of those deaths come from individuals who obviously get later, they've been detected later. And then others, they dropped off their medications too early. So you've got these sort of error rates on both sides. And so you have a nurse or someone in the community, ASHA worker, someone helping, engaging. And so you could think about politicians saying, okay, do I have to fund a new program to do this technology? Or it turns out they've come up with an entirely new AI-based detection system, and they found 25% more tuberculosis cases, not because they've educated, but they've introduced a whole new concept that you can change the diagnosis model through voice. You cough into a phone and it tells you, I'm paraphrasing what I heard earlier today. So this is the moment where the more we have flexibility in the political dialogue, and some say this is zero-based budgeting that's changed the way we fund our government. There are lots of policy debates. But if you start with the principle that there's a problem to be solved, we have too many people dying from tuberculosis too early. Now, let me say, look, we've got programming and funding and staff and people that do things to do this, but now a new technology shows up that allows me to think of this in an entirely new way and only possible to implement the strategies that come from this because it exists. That is a whole level of training that's not training, oh, here's how the buttons work. That is connecting the dots on what the capacity is to fundamentally reimagine the way to go about this. And so, not to go back to capacity building, but I have coined this term innovation pipeline management in government. DARPA, very famously, it's our research arm in the US government, sets ambitious but achievable targets and then lets professors, entrepreneurs, innovators sort of come up with ideas. And so you want to have a stage gate to test ideas. You want to test more ideas. Then some of them graduate to the next stage, and then you want to sort of validate those successes. And then you want policymakers to scale the ideas that work. And so I think your question was meant to, it was sort of funny. The politicians need to be trained. But there's also some seriousness, which is it can also be the vehicle by which we fundamentally reimagine the way to go about it. And then that brings a whole new cycle. So that's the positive side of where I think this could go.
Thank you, Anish, so much. And now let's get to the public questions. So any audience questions? Yeah, you first.
Hi, everyone. Thank you for your inputs. As someone who has been as an entrepreneur, also coming from a academic background, researching brain and AI, and has spent a lot of time in the US, last 20 years between US and India.
Be specific to the question because we have less time here.
Context to what we're discussing, the need for the digital health courses. So if somebody's come up with a solution for mental health, for the professionals themselves, like the nurses and the doctors, what will be the good platform? Because right now it's like you educate them for the need of it and then the skills and the outcome get measured. What will be a better way to scale this? Because the need is there. We see it. We work with kids also doing that. And we see the same need for professionals as well, right? And it's contextualized to the Indian context as well. What will be the good platform to sort of take this to scale when such needs exist with all professions as well? I do have a separate question on the pricing with India. So as two ventures that I've been part of that have scaled pretty well in the US, one of them has become 100 million revenue. The other has taken public route in the US, but they failed miserably on the pricing here. So spending 2 years upfront here, we couldn't get the same product to work at the pricing here. So what are your suggestions for how to make pricing work for India when you have the intent to solve for India as well?
So
those are my two questions.
Pricing part I'll start now because if you go back and look to GDHS session on pricing of digital health, you will get a detailed answer from those who build it globally. So that will help you solve that problem. On the other one, does someone want to take and answer it? Yeah.
So my guidance on how to take it forward when you have a working solution that's already working with B2C format, but we want to take it up for a larger scale up.
So, answering your question from the regulatory point, so we have for the nurses, we have linked 150 CNE hours and we have linked it to the renewal of their registration every 5 years. So now nurses have to mandatorily do these courses. Then only their license will get renewed. So there's a lot of need to have these kinds of courses. There are some platforms where these courses are put free of cost, INC being one of them. There's iGot, there's Swayam. So I'm sure there are a lot of opportunities for you to, take up anything that works for the nurses. The technical experts have to, take a look at it to see if it's okay, and then we can take it
So
from
right
there.
now it's developed by doctors for doctors, but it can certainly be. I'd love to take inputs from you where to take it forward.
We can
Thank
do
you.
it after this. Dr. Faridi, yeah.
Thank you very much. My very simple question is that I am born before technology and suddenly bombarded with the last 4-5 years. And the times are like this, the fate has this that I've from best colleges being a faculty and now joined Era Medical Colleges, Dean Faculty of Medicine. And suddenly this institution is in a hole into AI. Now, people like me who worked with MCI and the curriculum has already been changed, but believe me that nothing has changed because I actually had an audition also. My question is that how are you emphasizing in future that people who are supposed to implement AI, people who are supposed to train these people, Gen Z now, who themselves have not been trained. So there's a dilemma between them. Do you have any solution for that? So that at least the people who are being trained now are being trained by people who are, inverted commas, not trained. That's my worry.
So I will ask Era only to answer it in 1 minute.
Yes. So I think there are still people far and few in between who can be those ambassadors for change. It's just a matter of giving them the tools, being able to, get them on the platform of Era University or Digital Health Sciences Academy, so that they're able to train or build capacity at scale. That's the only way. Otherwise, we don't have enough people to do it one-on-one or in a physical capacity. We have to use virtual tools even for that. And at the same time, I think there shouldn't be a bar of a certain experience or a number of years of teaching for these kind of courses. So this has to be age agnostic, I feel.
Rajiv, 30 seconds for you, and then we have to close this. No, we have to close because we are running out of time. We have to launch also one thing. So,
So I think answer lies in the system itself. If I just give one example, remote surgeries. The doctors who were trained 30 years ago, they were not trained on remote surgeries. Today they are doing remote surgeries. How did they shift? So, I mean, this is something, I don't think that these trainings and capacity building should be restricted to the from within the profession. Whosoever is suitable for those trainings, they should be engaged. It's a continuous process in regulatory system. Our inspectors and drug controllers, they actually are trained into the modern in basically approving and reviewing these medical devices also. It was not there when they were appointed. So everybody is getting upgradation and there are systems to do it.
yeah, and in our courses, we have seen 80% of the people are, above 20 years, highest is 50 years after MBBS. So I think age is not a thing, it's a mindset thing.
Rajan,
So
I'd also like to add about the consortium of innovative healthcare
We'll do that.
universities.
So we have to launch this and close this session. We have a very strict timing here. And I see that clock ticking up. So
I understand.
So we're launching the Global AI Academy, which you will see is about training people. You have platforms. It's not about that. Together, yes.
Ready? Yeah, push the button. Here we go. Something's happening. There it is. The screen. Oh, that is coming.
It's coming and going.
There
Yeah.
it is.
Yeah.
Yay!
So it's never about the platform. It's about the mindset. And start now if you have not it. Thank you. Thank you very much. A big round of applause. Thank you.